Well, hello, hello, good evening, everybody. Welcome back to the show. We are so glad that you're here. Hopefully, you had a great Monday and a great weekend, actually. So glad that you're here. This is Dr. Dwayne Wood. That's Wood with an E, and the E stands for endocrinology. At this channel, on this channel, we help to educate you, empower you, and encourage you to take charge of your health and your life. Tonight, we've got a great show. We are excited about what we're talking about tonight. You saw the little graphic. If you've been on social media, you saw that we are talking about endometriosis, the treatment of endometriosis. What does endometriosis do to the body? That's what we're discussing tonight. And we've got a special guest that's going to be with us to help us have that discussion. We'll introduce her here in a little bit. If you are new to the channel, we love to welcome you and to say hello. So please go ahead and put new in the chat, in the comments, so that we know that you are new to the channel. If you have questions as we go through the evening, go ahead and put those in the chat as well, and we will be happy to grab those and we'll answer those as we get into the show. So once again, welcome. If you're new, you'll see that down there we have, if you're new, put that in the chat. And then an example of what your question should look like. There you go. Okay. We love when you have questions. If you've not already done so, please go ahead and check us out on all of our social media platforms. We've got LinkedIn, TikTok, of course, here on our show, and then our Twitter page. And if you'd like to support the channel, buymeacoffee.com. Every Monday night, we are here live at 7 o'clock, and so excited to have you come by and spend some time with us. If you're interested in more of our exciting content, you'll see there our live, of course, as I mentioned several times, here on Mondays, and then our TikTok, which comes out on Fridays. And I keep saying that we're changing that. If you've seen our social media, you will see that we have been ramping that up, and sometimes I'm up late at night and I'll just post something. But officially, we have a social media posts that are coming out on Thursdays, Fridays, on TikTok, and then on Twitter at 9 a.m. every morning. That also comes out. It comes out actually at 3 o'clock in the morning and at 9 a.m. So I don't know what am I doing up at that time, but that's okay. That's okay. So glad that you're here. So we're going to go ahead and get started. And tonight we have a special guest, like I said, Dr. Lilith White, who is one of the obstetricians here in town, gynecologist. Let me get this off the screen so you can actually see me. There you go. Okay. And I've known her for some time. We went to the same school, Oakwood University, as you guys know, because we rep that all the time. And she is here in town. We're going to give her a chance to kind of tell us a little bit about herself. So why don't we go ahead and just get her up on stage to join us right now. Dr. White, thank you for joining us tonight. Glad that you're here. Let me give you a little, there you go, some music. There you go.
Thanks for having me.
Oh, yeah. So glad that you took the time to be here. We were just talking a little while ago that there are some things going on right now with our young ones that hopefully somebody's doing some videotaping for us, right?
Yes, exactly. Yes, my daughter, who is graduating senior this year, is getting her honors tonight.
Yeah.
To give you a heart-to-heart talk on endometriosis.
There you look at that, man. This is what we call dedication. So thank you. So why don't we do this? Why don't you go ahead and take a brief 30 seconds maybe and tell us a little bit about you, about what's going on, who you are, so our viewers can get a little chance to get to know you a bit.
Okay, my name is Lilith White, and like Dr. Wood said, I'm an obstetrician gynecologist here in the Huntsville area. Recently relocated from Atlanta in 2016 and opened my practice. I'm solo practicing. In 2017, I opened. And I practice obstetrics, which is the delivery of babies, and then gynecology, which is primary care for women. A lot of people hear the obstetrics and gynecology and think, oh, I don't need you anymore. I'm through with my childbearing years and I'm done with obstetricians and gynecologists. Well, no, we go from, like I say, from adolescence to 99 because we deal with menopause and beyond as gynecologists. And I am accepting new patients. I am a holistic practicing physician, which means that I don't just believe in physical health, but spiritual, mental, emotional health. I'm very excited to do heart to heart talks often in the community where we discuss women's health because I feel that's very important. And I'm a Christian doctor. I often pray with my patients as well. And I'm excited to be on the show tonight to talk about endometriosis.
Awesome, awesome. Well, thank you for that. So let's just jump right in. Now, before we do that, though, you said something there that I want to make sure that we highlight. Okay, a lot of people, women as well, think that once they get beyond that childbearing age, they no longer need your services. And I see a lot of patients who are in our office, and I say to them, who's your OB-GYN? They say, oh yeah, I don't see them anymore. So take another minute and talk a little bit about that. What message do you want people to get in that area?
Well, the gynecologist, like I said, is the primary care physician, so to speak, for a female. So we deal with preventive medicine in terms of the breast, in terms of the ovaries, the tubes, the uterus, and the cervix. So we do screening for cervical cancer with the pap smear, and we do the breast exams and order mammograms like the primary care physician does as well. But we also do pelvic exams and, assess the ovaries, the tubes, and the uterus. So it's a very important component to have annually. And I do want to throw a plug in right now. People are very kind of confused a little with the new recommendations for cervical cancer because oftentimes you hear some of us as healthcare providers, we're a little confused as well when we hear that people don't have any risk of cervical cancer because they've never had an abnormal pap smear. We say, well, we don't need to see you at every 3 to 5 years. Well, the misinformation there is we don't need to do a pap smear every 3 to 5 years. But we still need to see you annually because, of your other female organs, your breasts, your uterus, your ovaries, your tubes, and just to see how, you're doing annually. So you may not have to have the pap that you just desire to have annually, I'm sure. No, but you still have to get a full assessment yearly.
Okay, so very important that people know that even if they are beyond the childbearing age, that they should still see or seek service because you really are the primary care for women.
Mm-hmm. And I've
And
seen, yeah.
Go
Oh, go
ahead, go
ahead.
ahead.
No, I've seen plenty of women come to me, for instance, and they'll on the abdominal exam, I feel a huge mass, and I'm like, "What is this?" And I know they're not pregnant; they're in their 40s and 50s, and they say, "Oh, I was told that was scar tissue," and
Mm,
that's the reason why you come to me. I had a woman that had fibroids up to her diaphragm.
wow.
So she had some huge fibroids and we had to take them out. Thank God it wasn't cancer because sometimes when we're following people, if we see a rapid growth of fibroids, even though they're benign, that could be indicative of cancer.
Right. Now, the other group of people I think it's important to mention here are women who have had a hysterectomy. Because sometimes it's, okay, I'm not beyond childbearing age, right? But I don't have a uterus, so I don't need to go see that doctor. What do you say to that?
So I still tell people if you have your uterus and tubes, and sometimes people say, I had all that taken out, you still have a breast, you still have breasts, and you still have a vulva, which is the outside of your vagina. You still have your vagina because you can get vaginal cancer, you can get vulvar cancer. And most importantly, just for quality of life with menopausal monitoring and management, and just like I said, breast cancer screening and checking that area down there to make sure everything's healthy. A lot of times we also are the physician that sees the urine disturbances. Sometimes women have problems because of the lack of estrogen holding urine and not being incontinent. So we're the ones that will be the gatekeeper there and send them to the urologist or the urogynecologist or whoever.
Wow. Okay. Okay. So well worth for all women to be able
Yeah,
to come and
absolutely.
visit. Okay. All right. So that's not even the conversation, but that we can have a whole show on on
Oh yeah,
that.
we can. I'm sorry to veer off on that.
No. That's good. I'm
No, this
happy.
passion.
You women's health is something that sometimes is overlooked. And I think it's worth us really making those plugs because there's so much misunderstanding on what an OB-GYN does, right? So people know the obstetric part. And sometimes I want to say, no, go see the gynecologist. I want to take the obstetric part away and say, no, you need to go see the gynecologist. But okay. All right. So endometriosis, right? That's what we're going to talk about tonight. What I read was 1 out of 10 women suffer from endometriosis. And before we even get to what endometriosis is, why don't you give us a little backdrop on the menstrual cycle? What happens during a menstrual cycle for those who are watching?
Okay. And I want to throw that plug in too. Endometriosis is another reason why you see your gynecologist if you're not in childbearing age. All of these different diseases, but menstrual cycle. Well, essentially, just to keep it simple. So, menstrual cycles are preparation for pregnancy. So, when a girl has her menarche, the first period in her life or menstrual period, she is now prepared to try to have, of course, we don't want them at that young age, but to start preparing for pregnancy. So there's 2 phases in the menstrual cycle, the proliferative phase and then the secretory phase. And in the proliferative phase, the estrogen builds up and it's allowing the tissues and the lining of the uterus to increase in layers and prepare the baby that is supposed to be born if there's an egg and a sperm to meet and fertilize to have a cushioned environment and a healthy environment. And the progesterone increases around this time as well. So the egg drops from the ovary, that's called ovulation. And if there's a sperm around, it travels through the uterus. The egg comes from the ovary through the fallopian tube, meets the sperm in the uterus, and then we have a zygote and we have a baby. And it implants itself in the uterus, and pregnancy just goes from there. If there's no sperm, then the estrogen level and the progesterone level decrease, and that uterine lining sheds, and then you have a menstrual period. And the cycle, that whole process is your menstrual cycle. The most common number of days for the menstrual cycle is 23 days, but it can be 28 days, every 28 days, every 23 days. Usually, if you take birth control pills, it can be every 28 days that you see that cycle. But that essentially is the physiology of the menstrual cycle. And during that time, when the tissue breaks down, if there's no sperm there and no baby formed, then all of that inflammation and swelling and growth gets shed, and the damaged tissue kind of like excretes through the vagina outside of the body, and then the process starts over.
Okay, so basically that's the menstrual cycle, and in this process, the uterine lining is proliferating.
Yes, in the
Is
beginning,
that
that's the proliferative phase, and
the
then the
proliferative
secret
phase?
phase, yeah, if there's nothing there, then it just gets wasted.
Right.
Yeah.
And so that's the backdrop, and I wanted people to kind of understand that because as we talk about endometriosis really has to do with that uterine tissue. So tell us what is the definition of what is endometriosis?
Okay. So besides being another one of our female woes with menstrual cycles bleeding every month and cramping and having pain in childbirth and then getting into our season years and having the menopause and its inconveniences, we have endometriosis. But the good news, like Dr. Wood said, is only 10% of women are plagued with it instead of everybody. Like in menstrual cycles, every woman is plagued with it. Menopause, every woman is plagued with it. But with endometriosis, that intrauterine lining decides to say, hey, I want to relocate. I want to leave my home, which is the uterine cavity or the womb, and I want to go live elsewhere. And the most common place for it to go is the pelvic cavity, specifically around the female organs. So you'll see it around the fallopian tubes, which are alongside the uterine cavity or the uterus. You can see it in the ovaries, and that's the most common site for it, actually, is in the ovaries. And even though it leaves the intrauterine cavity of the uterus, it can probably kind of go along the outside wall of the uterus in some cases too. It can go along the pelvic side walls, and less commonly, it can get along the intestine and the bladder. And it can even go to the cul-de-sac, which is the space behind the uterus. So, depending on where it is, that can kind of shape your symptoms.
Wow, wow. So endometrium or endometrial tissue outside of the uterus depositing really, and from my reading or from remembering medical school and so forth, it can be found almost anywhere, right?
Oh, yeah. Let me tell you, there's a case report now. I remember this one in training and actually even in practicing. Um, there was a implant, because this is what we call them, implants. This tissue that goes elsewhere is called like an endometrial implant. I remember reading a case report where it was in a surgical incision site. And it was so difficult to diagnose because the patient kept saying she was having pain there. They were like, well, yeah, you've been cut there, you had surgery there. But it just prolonged itself, that pain, for 3 to 4 to 5 months. So they went back in, did surgery, couldn't find anything. And then finally, they just saw a little beefy, purplish, reddish, tissue in her incision, like where the subcutaneous tissue is. And they decided to biopsy it. And it was an endometrial implant. And
Oh
when
my
it was
goodness.
removed, she was relieved. Yeah.
In the surgical incision.
So it's rare, but
Wow,
it
wow.
happen. Yes. So,
So really, for me, as I'm thinking about this, so if I'm having, backache, back pain, stomach ache, pain in my leg, pain in my neck, should I be thinking endometriosis? Well, not
well,
me, but hopefully not me. Because if that happens, you're writing a paper, right?
exactly. You'd be famous. Well, you've touched on one of my pet peeves, and that is using non-specific symptoms and just coming up with a diagnosis. And a lot of times when you sit and have that roundtable discussion with a lot of your girlfriends, you'll say, oh, I had that. That has to be this. Or I had that, and that has to be this. So what you just described, back pain, pelvic pain, bleeding, it's not something that can specifically say, wow, that's definitely endometriosis, because it can be a few, other things can cause that as well. Quite a few things: fibroids, just regular menstrual cramps, maybe having weight gain, because weight gain can cause bleeding abnormalities, and it can cause back pain because it's more weight on the torso. And I always tell people that diagnose themselves with bladder infections, they call me, Dr. White, I need another this or that, this antibiotic. And I'm like, how do you know what you have? So you have to come in. And after this talk, you'll see that when endometriosis is on the bladder, which it very well can be detected, you can get dysuria or painful, urination and pain in the bladder area. And that doesn't, clue you in to say this is definitely a bladder infection. It could be just simply endometriosis. And that's why you need to come to the doctor and get a diagnosis.
Right, right. So if you were to give some symptoms, and I know you just said you can't just use non-specific. If
Right.
you were to give some symptoms of true endometrial pain, right? And the reason I'm harping on pain is it seems like a lot of people will have pain, and the pain will go undiagnosed as endometriosis, and it'll be called something else, right? So if you were to give maybe 2 or 3 of your top, okay, these are the types of things that you would see if you have endometriosis in terms of symptoms, what would they be?
Okay. Number one is pelvic pain. You can't have endometriosis without pelvic pain. Everybody that I know that has endometriosis has some kind of pain. Now, it gets tricky because everybody has a different way of describing how they feel. Some people are more stoic than others, but when you're a good clinician, and when I say good clinician, one that listens and one that asks the right questions and spends some time with your patients, patients may refer to pain as cramping. And I always try to tell them, now I need you to be specific, because for me to do further testing and maybe further procedures, the insurance wants to see that it is warranted, like that I should be doing this. So if you don't have any symptoms, then we can just, just curtail this interview and just go ahead and do your preventive physical and call it quits. But when you really let people know that, it's important that their history is accurate, because as we learned, Dr. Wood, 90+% of the diagnosis comes from the history and the physical. So that's really important. But the symptoms that I would say are really kind of evident that there's something going on in terms of endometriosis are pelvic pain, heavy bleeding, and the pain doesn't have to be dysmenorrhea, which is pain during the menses. It can be pain just throughout the menstrual cycle. You may not be having your menstrual period, but you have pelvic pain and it's intense. It may intensify during the cycle, but you have it. And sometimes it can be just before the cycle or during the cycle, and sometimes it can be throughout the menstrual cycle. So it can be during the menstrual period only, or right before, or throughout the whole menstrual cycle, the 23 or 28 days. So the pelvic pain, the bleeding, you can have painful sex, you can have painful defecation and painful urination. What is defecation? A bowel movement. So as we talked about earlier, the locations for the endometrial implants, if it's on the intestine, you can have painful bowel movements. If it's on the bladder, you can have painful urination or pain when you have to use the bathroom, or you find yourself having to use it more frequently than not. And every time they test for a bladder infection, it's negative. The bleeding can be heavy, and so a lot of times you have your healthcare provider order a pelvic vaginal ultrasound, and they don't see any uterine masses, so they're like, well, it's not fibroids. And that's another ball game there too, because you can have ultrasounds that come up negative, and patients may have very small, unrecognizable fibroids that can only be seen surgically, or even not until the pathologist cuts the uterus open and sees small, multiple fibroids. But that's usually rare. They're usually seen by ultrasound. And then we usually will do the gold standard, the laparoscopy, because that's when we go in, like a colonoscopy goes in with a camera in your colon. The laparoscopy goes in your belly, and usually around your belly button with a camera, and we look in and we do surgery that way. And we can look in and look for just particular lesions that we know and recognize as endometriosis. You can have a cyst too. Those are called chocolate cysts. Usually the reason why they're called that is because they're thick, brownish, look like fudge. When you go in, kind of nasty, but yeah, and that's an endometrioma. So that's when the endometriosis buries itself in the ovary, and it causes cystic fluid to look thick and dark brownish. And those need to be usually taken out. But yeah,
Oh,
those are the main symptoms and the reason why pain is so, and I don't know if I'm talking too much, you can
no, no,
stop
no.
me.
Go right ahead. Yeah.
But the reason why there's so much pain is because, like, I like the way Dr. Wood said, let's talk about the menstrual cycle. Because you know that when you go through the secretory phase, that's when the tissue breaks down, it's damaged, but the Lord allows it to be excreted through the body. Well, when you have these implants in the pelvic cavity, there's nowhere to be excreted. So you have all this tissue that builds up. And what does it do? It's still influenced by the hormones during your cycle. So it tries to grow, swell up, cause inflammation, irritation, and sometimes it gets sticky. So it can form scar tissue, and sometimes it can cause organs to stick to each other. That is very uncomfortable. And of course, that's a big contributor to the pain. And that's the reason why people have pain outside of the menstrual period, because sometimes when it sticks, you could just make a certain movement and hurt. You could turn and twist, and it could aggravate those organs that are stuck together and cause excruciating pain. So it just depends on the extent of your disease. And I know that maybe if you guys have been reading a little bit in depth, sometimes it's weird, but some of the patients that have the most extensive disease, when we go in laparoscopically, they have the least amount of pain when it comes to some of the other patients that just have speckled patterns of implants around or maybe even one implant down in the cul-de-sac region. Don't know why that is. And then sometimes that doesn't, sometimes that doesn't apply. Some people that have all the extensive disease do have the pain.
Yeah, that
So
was an interesting point for me, that the extent of the disease does not necessarily correlate with the extent of the pain. That you can have someone who has significant disease that has minimal pain, and someone who has a small disease that have, these excruciating issues that they go through every month.
Yeah.
So that was an interesting one. Now, the
I
one
don't know
thing
if they built up tolerance, I don't know. It's been growing
okay,
there so long and they built up tolerance. That's
right.
interesting. Yeah.
Yeah, one of the things that you mentioned, and of course, whenever I hear the word hormone, my ears stick up, right? Because that's what I do. Let's go back and talk about the hormonal influence on endometriosis. Tell me a little bit about what causes it to really act up around the menstrual cycle times.
Well, it's influenced by estrogen. So when estrogen is going through the proliferative phase of building the lining of the intrauterine cavity up, but yet you have these wandering implants that have gone and seated themselves in the pelvic cavity, they're still influenced by the estrogen. So they grow, they swell, they inflame, they bleed. And because they're outside of the lining that they were created to be in, now that they're in the pelvic cavity and there's nowhere to just kind of break down and excrete themselves and disappear, they just form tissue and form irritation and inflammation. And it's, just a cycle that's, can be really devastating for some women.
Right, right. Now,
Mhm.
what do we really know what causes endometriosis? I know there are several theories of what it is.
Yeah.
Probably it is the most common kind of retrograde menstrual cycle. Is that talk a little bit about that for me?
Yeah, but we clinicians don't really kind of go through that because really the take home message is like with fibroids, there is no etiology. They don't know. I mean, they don't know it. It's an unknown etiology, unknown cause. But yeah, the retrograde menstruation just means that it kind of like instead of going out the body, it goes up and through the fallopian tube and seeds into the outside of the fallopian tube and into the pelvic cavity. But that's not it hasn't been proven and it doesn't have consistency with the way they theorize it. So yeah, I just tell patients basically there's no known cause.
There's no known cause.
There's no known
because
cause
like a
don't
lot of
know.
things that I do, I'll tell patients, yeah, that may be the cause, but the treatment is the same. I mean, we're gonna evaluate it, we're gonna treat it. So it's kind of, I don't want to say academic to spend some time trying to figure out what caused it, but how do we treat it, I guess is the thing. Now the other surprising thing for me was to find out the length of time that some women go before they're actually diagnosed with endometriosis. I saw somewhere, I mean, 5 years, 6 years sometimes, or more.
Oh yeah, it's more commonly maybe 10 plus because
Mm.
what I found in my 30 years of practicing, maybe 25 years of practicing. I know I'm aging myself, but is that a lot of young girls, because of their menstrual cycles being heavy and irregular, get on birth control pills. And birth
Right.
control pills are one of the treatments for endometriosis. So they're masking it. So
Mm.
until it gets extensive or bad, or they get off the pill for some years and then discover, oh, this pain is pretty intense, then they get the diagnosis. But a lot of times we're on things that help it, or it may have started and not gotten as extensive yet. Just like I don't know if I'm going off with this, but people with lupus, some
Mhm.
people have severe lupus, and some people die in their adolescence. I've seen a friend of mine's sister die at 18, but then I
Mm.
saw another friend of mine's mother live till in her 80s. So,
Wow.
I guess it just depends on how the genetics play into things and lifestyle, how it would, spread or, kind of like grow even more to the point where you
Right.
have treatment.
Okay. Well, so so we're let's kind of walk through this a little bit. So we've got a young woman who maybe she's not even on birth control, and she's having these excruciating episodes as she gets into her menstrual cycle, and they're coming maybe once a month. Maybe they last a couple of days through her cycle, and then they go away, and then they come back the next month, and then they go away. And let's assume that she doesn't go on the birth control for whatever reason. What would be a reason for that someone would, I don't know, maybe just kind of endure that?
What I found, and this is kind of common with fibroids too, some people just adapt things as their norm. My
Mm,
mom did it. My grandmom bled a lot. And that's how I know that the psychological factors in
mm,
somebody's stamina are powerful. If you think, oh, this is nothing, I can endure this. My mom went through this, my grandmother, my aunt, then you kind of like process a perseverance and stamina to just withstand it and say, this is just the norm. This is something I'll have to do every month. It's not a big deal for me to need a heating pad. It's not a big deal for my mother to have to come get me out of school, and I have to lay out. And, I'll never forget, Dr. Wood, when we were in school, we had, I'm not sure, I can't remember, but I think this individual had to, well, I know she had to leave classes for like
hmm
3 or 5 days out of the cycle.
Wow.
And they had to get some medicine she was on from California shipped to her.
Mm,
And sometimes people just accept that. But I'm here to tell you, and I'm glad you're having this show, you do not have to accept that. Come to the gynecologist, get help. Some people don't even consider their bleeding heavy because the way they quantify it, like I say, everything's relative to what you're used to. So if
right,
everybody in your family bleeds and they change a pad every 3 hours, that's not heavy for you. But
right,
that is
right.
heavy. That's a
Wow,
heavy
wow.
cycle. So I tell people, if your heavy days, you're changing a pad every 2 to 3 hours, sometime every four, that's a lot.
Mm-hmm.
Like 6 times a day in a 24-hour period or more, that's a lot. And if you see in clots, but sometimes if they don't know, like I tell them, ignorance is bliss. So you learn to be happy because you really don't even know what's going on with you.
Wow.
Um, so that's what usually happens.
So
And if
basically they normalize it.
Yeah, they normalize it. It becomes their
Wow.
norm. And I
Yeah.
try to tell people it doesn't have to be your norm. So many people have thanked some of us gynecologists because they say, oh, like, thank you for taking my uterus out. I didn't even know I was unhappy until I had my uterus taken out. Now I see I can live. I have quality
Mm-hmm.
of life. I have
Right.
energy. I can, just mobilize and, be happy and lose weight. Because I tell people, when you're unhappy and you can get depressed from being unhappy. For women, food is our drug of choice sometimes.
Watch it now.
No.
Yeah, we did a show, and I'll put a link in the description. We did a show on stress and weight. We did a show on how the adrenals responds during stress, and so you're right. Now, so we've been talking about pain. Okay, tell me, are there other complications aside from pain that relate to endometriosis? What other things can happen to somebody?
So, in fertility patients, 4 out of 10 of them have endometriosis.
Mm,
So now, not everybody with endometriosis it has infertility. I've seen people have babies and they have endometriosis. Just like with PCOS, they say, oh, they don't get pregnant, but they can get pregnant. So usually we see infertility issues because the tissue and everything that goes on can damage the sperm, damage the egg, and actually we talked about sticking of structures to each other and scar tissue. If that happens along the fallopian tubes, then the egg, when it tries to travel through the fallopian tube, is blocked. And if it's blocked, then the sperm can't meet the egg, and then you can't get pregnant if your tubes are blocked. So that's kind of one of the woes of endometriosis, besides the pain and the lack of quality of life, from that pain. And then, of course, the bleeding and depending on how severe the bleeding is, the feelings of chronic fatigue, which can cause depression, the lightheadedness, the syncopal episodes, the need for iron transfusions, blood transfusions, with the risk there involved. So yeah, it can get pretty extensive. So that's one of the things, along with, you know, um, just, having marital issues, because sex becomes a problem too. If sex is painful, then, that can really kind of put just, a heavy weight on the male ego, because, you don't want to have sex, but it has nothing to do with him. It's just that it's uncomfortable. So yeah, these are things that can, just, cause some real life issues.
Right, right. And and I want everybody to remember, and as we're talking, this is not just an academic discussion, right? So these are,
Yeah.
you know, uh, think about a woman who is in such excruciating pain, as she gets into her cycle, that she's taking, days off out of her life. She's just like, leave me alone, don't bother me right now. Whether it's work, whether it's family, whether it's school, or something that she likes to do, she's got to take time away from that. And sometimes people don't understand. We've talked about some of those syncopal episodes, or some of the other things that go on in fertility. Can you imagine what a woman feels when she is ready to have a family, and for some reason that is not happening? And sometimes, guys, we can be insensitive. It's like, well, it's not my fault, but it can be endometriosis. And then add on top of that, the discomfort of intercourse. And this is one that is so important. I see it a lot in, not the discomfort, but I see a lot in my diabetics, because a lot of diabetics are having issues with erectile dysfunction and so forth. And they'll come to the doctor. We'll talk about everything else, but they won't bring up this part of their life, because it's an embarrassment to them. And so I can't imagine what a woman feels when she is in the process of this pain or the discomfort, to think, oh my goodness, right? What happens to my marriage? What happens to my relationship? And so basically we're making a decision between pain and, marital intercourse.
Mm-hmm.
Wow,
And
wow.
it gets even deeper, because I've had patients call me that were just trying to contemplate surgery or not, because that's another treatment. And of course, um, when you can do surgery once the childbearing is over, just take out the uterus and the ovaries, and usually you're good. Now, every
Right.
now and then, very rarely, somebody will have to go after the bowel and the bladder, because I mentioned earlier that it can spread there, but that's very rare. But just imagine people. I've had a lady call me one time from a theater, and she said she was trying to make a decision if she wanted the hysterectomy, and she was finished with her childbearing. She was in her 50s. I didn't understand why, because she was having a lot of problems. She said that she was in the bathroom trying to call her husband on the cell phone to bring her coat, because she had soiled her outfit. But because
Mm,
it was a concert, it was so loud, she couldn't get him on the cell phone. And she was trying to figure out, how am I going to go out there like this?
right.
Of course it was dark, so she was able to get an usher or somebody to get him. She got her coat and they left, and she said,
Mm,
Dr. White, I'm ready for the surgery. So it
wow.
can get really bad, because you don't just have bleeding, but it's unwarned bleeding, unpredictable bleeding, sometimes unpredictable pain. It's bad enough when your cycle's going to come on and you say, okay, in the middle of the month, I know I'm going to have this pain. But with endometriosis, and sometimes even with fibroids, this pain can come on anytime. It's not just during the cycle. And when it hits you, depending on where you are, it can be embarrassing, and it can be, just very upsetting and disappointing. So,
Right.
it really can bear heavily on your lifestyle, on your, just your happiness, your peace of mind, all of that.
Right, right. Wow, wow. Okay, so we're gonna pivot in a minute on the other side of these announcements, but we're gonna talk now, and when we come back, about, okay, there's some hope for our women, right? So
Yes, there's
so hang
hope.
on, let's do that. So guys, if you have not already done so, please go ahead and check us out on all our social media platforms. LinkedIn, TikTok, of course, here on our show on Mondays, Twitter, and then Buy Me a Coffee. Remember that our show is a place where we do health talk, we do wellness talk. You have an exclusive seat to listen and to interact with our special guests like we're doing tonight, Dr. Lilith White. Also, remember our coaching services for life coaching, for diabetes coaching. And recently, if you have not already seen the videos that I did on the physician entrepreneur, please make sure you do that. Send it to your doctors, right? So we're trying to get doctors to realize that they can be fulfilled because healthcare has changed so much that we're finding a lot of physicians that are dissatisfied with where they are. The book that we are using as our basis is the Entree MD Method by Dr. Una, the Entree MD. And so we have those videos that we've done. We've done 2 so far. We've got a few more in that series, and then we're going to expand that series to include some other things. So if you have a doctor that you are concerned about, have a doctor that you love, go ahead and send those videos to them so they can watch them. Remember also that we have our subscription service for our patients, for those who want to get more of our content. There are 3 levels there: the starter pack, the learner pack, and the advanced pack. And for each of those, you get to spend some time with me. And with the advanced pack, there is a free 60-minute coaching session that you get where we sit down and we do an actual coaching session with you to evaluate and to help you get unstuck, because that's what we find a lot, that there are people who are stuck where they are, and our goal is to help you to get beyond that. So thank you, and we look forward to interacting with you, and so glad that we are here. So let's go ahead and get Dr. White back on the screen. Wow, an amazing conversation so far. Amazing conversation. So 2 things that I want to jump back. One, tell me a little bit more about the actual diagnosis of endometriosis. And then we're going to pivot and talk about, okay, now what do we do?
Okay, so another important point I failed to mention was imaging is not good for diagnosing endometriosis. Some people say, well, I had my pelvic ultrasound and vaginal ultrasound and they didn't find anything. Or I had a CT scan of my pelvis and my abdomen. Well, those are not the gold standard for looking at endometriosis. The gold standard is the laparoscopy, looking in, seeing the lesions. And some people will not just see them and be satisfied. They want to biopsy them and send them to the pathologist and see the macrophages and everything else that should be in there. But a lot of times, I know, Dr. Wood, you mentioned earlier when we see the younger girls, because usually I failed to mention also that endometriosis, even though it's an incidence of 1 in 10, it usually is only found in reproductive age women, which are women between 30 and 40. However, we gynecologists, if you know we have any gynecologists out there listening, we know we've seen them in 20-year-olds and we've seen them even in 18-year-olds. So a lot of times when we have a young girl like that come to us, the first thing we're thinking of is not surgery. And even in older women, you want to always try the least invasive approach. So you want to start off with some kind of medical, maybe even over the counter, Aleve, Advil, Motrin. And some people say, well, I don't want that chronic usage. Well, you're not going to be using it chronically. You're only going to be using it a couple of days out of the month. So it's not going to have the same effect as somebody with arthritis that has to use it every day and 3 and 4 times a day. So that might be the first thing we start off with. And then we may jump to the hormonal. And with hormonal, you have the birth control pills. Now we have the patches. We have the vaginal rings. We have the depot shot. We have the implant that goes in the arm. We have the intrauterine device. And then there are the gonadotrophin releasing hormone agonists. All of these different pills and medicines, well, the first 3, the nonsteroidals, and Advil, Aleve, Motrin, all of that, that's analgesic, meaning it relieves the pain. But the others that are hormonal, they suppress ovulation. And when they suppress ovulation, they decrease the estrogen. And we spoke about the estrogen causing, influencing this tissue that gets implanted in the pelvic cavity to grow, get inflamed, start irritating, and sticking and causing scar tissue. So when you use these different agents, you decrease that. A take home point is, well, if I get on this will just eradicate all my endometrial implants or take away my endometriosis. No, it won't. It'll just prevent any perpetuation of the disease, meaning new implants will not come, or new tissue that is already there in the pelvic cavity will not grow and cause scar tissue and inflammation in other sites. But that's already there will be there. So that's why when people are still having symptoms that are significant enough after they've tried medical treatment with, hormones or analgesics, they have to go on and move on to surgery. Now, the surgery that we do initially is fertility sparing surgery, because like these women are in the reproductive age and they want to have children between 30 and 40. So we try to just see the lesions inside and burn them or destroy them. And sometimes it even involves taking out some of that tissue and just removing it from the pelvic cavity altogether. If it's an ovarian cyst, as we mentioned earlier, we remove the cyst. And we try to do that and then just leave the pelvic organs till the childbearing is over and put the person on suppressive therapy for maybe 6 months. And the suppressive therapy would be birth control. Now, you may say, well, they want to have kids. But right after the surgery, it's important to put them on something to boost what you've already done, to kind of, just solidify that these lesions that you've burned are gone, they're dead, that no hormonal influences will trigger them to reignite and grow again and cause inflammation. So you want to stay on those like 6 months or a year or something, and then try to have your children. Now, once you're finished with childbearing, the way to go would be the hysterectomy and getting the ovaries and the tubes removed if you just don't want any more symptoms, ever. And like I said, very rarely, sometimes the bowel and bladder may be involved, and that's when you can go to an endometriosis specialist. We do have those around, and they can deal with that. Maybe having to resect those areas, maybe not, but that would be a conversation you would have with that specialist. But you were talking about treatment. So that would be basically the treatment that's involved. In diagnosis, like I said, would be the history and physical, because somebody would be complaining about having irregular heavy periods. And once I do the imaging studies and don't see fibroids, that's the next thing we'll think about. And in young girls, we'll just jump right to the birth control pills. We don't have to do surgery. If they come back in 3 months and say they're feeling better, we're happy. Or if they do the analgesics with the nonsteroidals and all that and they feel better, we're happy. We'll just continue to follow them till they're not happy anymore. And then we'll go to the next level. But we always want to do the least invasive thing. And so we never look to ultrasound, CT scan, or any of that to tell us about scar tissue or endometrial implants, because it's not for that, and it won't give us any information on that. So
Right.
unless you have a cyst, an endometrioma. Yeah.
Okay. Now, so surgery. So even surgery, I was going to say surgery definitive cure, or definitive. Do we say cure or do we say management?
Actually, I say cure.
You
Because
say
the
cure.
patients
Okay.
that I've removed their ovaries and their tubes,
Right.
when I take it all out, they're done and they're happy.
They're happy.
They're happy.
Okay.
They think I'm
Uh,
something. I'm like, I'm just a vessel for God. He's
right.
done
Right.
that. Yeah, they're happy.
Now, are there because everybody is into wholeness and wellness and natural treatments, are there any dietary things that someone can do that or lifestyle things that people can do that will help with endometriosis?
Well, first of all, I know that we always try to promote, because, I do that as well, diet, exercise, and all these things. But remember, when people have endometriosis, they cannot exercise all the time. Sometimes they're bleeding so much, they're in so much pain. It just depends on the extent of the disease.
Hmm.
Of course, I tell people, a plant-based diet may be a lot better for them because of the hormones and different things, and the meats and things. But really, the pesticides and stuff are in the vegetables and everything else as well. But yeah, I do tell them the healthier you try to eat, of course, less stimulants, alcohol, tobacco, things like that, caffeine, because as you know, the PMS can get activated too with those stimulants, especially caffeine. So those things can contribute and worsen and intensify the endometriosis symptoms too, to make, you feel like you're just, need out of control and needing something. But exercise is definitely good if you can, because just like moms tell their daughters when they're younger and they're going into the cycle, the more you exercise, the less pain. Don't know why that is, but it's I don't know if the circulation is better and you just feel better, less cramping and things like that. And, in terms of, because there are certain diseases where holistic, it works. I never feel that it doesn't work, but there's some things that require, and that's why God has put doctors in place. It requires medical attention. Like,
Oh
like
my.
I was, this is
You
not
got you
like,
got to say that again. We have to say that again.
yeah, it's like when you get to a certain point, I know what you're saying, that, you're forgetting preventive versus treatment. Now, a lot of the things that we're talking about in terms of lifestyle changes that are healthy, those are preventive measures. Once you have a serious illness going on, you're no longer in preventive stage, you already have it. So
Right.
you're going to need something. And nobody's saying that you have to stay on something for the rest of your life, but you're going to need something till you develop the habits that can get you into a healthier lifestyle.
All
So,
right.
that's why God has given doctors, the wisdom and knowledge to do things to make sure that your quality of life is there.
Awesome. Awesome. Well, let's see. I think we've got, I guess, let's see. Oh, look at that. Dr. Charmaine. Hey, Dr. Charmaine, thank you for coming through. She says, great information. Thank you for talking about this
Dr.
topic.
Wood.
So, hey, Dr. Charmaine, glad that you're there. Glad that you're giving us a thumbs up out there. So one of the things that you mentioned earlier, and I'm going to step away from endometriosis for a moment, to say that the pain, the bleeding, the discomfort that comes around menstrual cycles are things that we have therapies for. So, and it doesn't have to be an endometriosis issue. It could be whatever that's surrounding your menstrual cycles. Please, please, please make sure that you are seeing and that you're talking to your gynecologist, because there are so many times when you are spending time away from your life that you don't have to, right? Because there's someone out there that can help you. So good. Well, this is a great place, guys. We're going to take a break here, Dr. White, and we're going to do our thought of the day. Hey guys, I am so excited to talk to you about this thought of the day. And the thought of the day is this. It comes from a quote that I read somewhere, and I'm not going to tell you the exact verbiage of the quote, but the idea was that life does not have a remote control. You've got to get up and you've got to change the channel yourself. I know that's a silly one, right? Now, I remember when I was growing up in New York, there are 6 kids. At the time, there were only 4 of us. So in my family, there are 3 boys, 3 girls. And I remember growing up, and I am old enough to remember when the TV did not have a remote, right? So it was sitting over there on the counter, and you had to actually get up and walk over and turn the channel. Yeah, I know a lot of you don't even remember that, right? Or realize that used to be a thing. But we would get up and we'd walk over and we'd change the remote or change the channel. Of course, back then we only had like 4 or 5 channels, but that's another story, right? So we had to physically get up and go do it. And so many times, guys, we have life, and life is just playing before us, and we're letting life do whatever it wants to do, because we think that somehow the channel is going to change, or this phase of life is going to pass, or this part of my life is going to get better. But guess what? You have got to be the channel changer. You have got to be the one that engages in your life. You've got to be the one that gets out there and tries new things. I've said before that I was listening to one of the people that I hear on YouTube, and she says, try as many things that make you uncomfortable as possible. Now, that can be scary for people, right? Because, oh my goodness, I don't want to do that. But guess what? You only get one life. This is it. Don't allow your problems with money, problems with relationships, problems with COVID, problems, right? So there are so many things that we can see, and it almost makes us afraid to step into our lives and to make a difference. But the only one that can make a difference in your life is you. Nobody else is going to show up magically and say, hey, let me change this for you. Let me change the TV. Let me change the channel. Let me take you out of this phase of your life. Let me take you out of this season. The person that gets to do that is you. You can make today an amazing day. You can make today the best or the beginning of the best part of your life. It doesn't matter what happened yesterday. It almost doesn't even matter what happened today. What matters is what you do going forward. So don't telescope your life. Don't allow the remote to manage your life. Get up. Engage in your life. Is it going to be painful? Yeah, there are going to be some things that are going to be painful. You are going to have some relationships that don't work. That's right, I said it. There are going to be some people in your life that are not going to like the new you. That happens. There are going to be some things in your life that you are going to have to struggle and fight to get over. But it is so worth it, because when you're engaged, when you're taking life by the throat, if you will, taking life by the collar and saying, no, I'm not just letting you run me ragged. I'm not letting you do what you want. I'm in charge. When you get that result, guys, when you get that result, gals, it is so empowering. And that's what we do here. We educate, we empower, and we encourage you. So my challenge for you today is to get up and get involved in your life. Don't treat it like a remote control TV. Now, let's go back to old school, right? Let's get up and let's change that channel. That's our thought for today. All right. Well, Dr. White, I am so excited. Thank you for being here. I mean, this is a wonderful conversation. Now, I hope you will let us invite you back, because there are so many things that we just touched the surface of as we were going through the talk tonight. So I hope you will allow us to do that. But why don't you take a few moments right now? I'm going to put you on the screen, and let's tell people about you, about your practice, some of the things that you're doing. How can they reach you if they want to reach you? Why don't you do that for us?
Okay. Once again, my name is Lalith White, and I'm an obstetrician gynecologist here in Huntsville. My office is like the address right here up on the screen, 185 Whitesport Drive, Southwest Suite 6, right around Crestwood Medical Center, right on Whitesburg and Airport Road at that corner. And it's Huntsville, Alabama 35801. The phone number is 256-937-7050. We are open Monday through Thursday, 8:30 to 5. Actually, Monday and Thursday, we have new hours now. We're 8:30 to 3. I'm sorry. And Tuesdays and Wednesdays are 8:30 to 5. Fridays, we're closed. And of course, closed on the weekend. We are accepting new patients. We'd love to have you come and service you as best we can. We do have holistic approaches where we don't just show concern about your physical health, but about your mental, emotional, spiritual health as well. I am a Christian physician, and I do offer prayer if you like that. We do not force it on anyone. And I remember Dr. Wood asking me a thought or something that I lived by when I was coming on the show, and I would like to just mention that. It's a biblical message, and it's from Matthew 6:25 through 34. And essentially, in a paraphrase version, is saying that we shouldn't really worry about anything. Some of the things we worry about are so trivial. like, what, I know this sounds crazy, but what we're going to eat or what we're going to drink or what we're going to wear and put on. It says if our Heavenly Father clothes the lilies of the field and takes care of the grass that's here today and gone tomorrow, so much, He will just do so much more for us because we're created in His image. So we don't need to worry about anything. Just like verse 33 tells us, if we just seek first His will for our lives, everything else will fall in place. And that last verse says we don't need to worry about tomorrow because sufficient is the evil today. So we have today now. We don't even know if we're going to have tomorrow. So we need to work with what we have today. So I would just like to say that.
All right. Well, thank you. Thank you so much. And once again, Dr. White, thank you for being with us. Thank you for sharing your knowledge with us. And we would look to see you in the future on the show.
Absolutely. Yes. Thank you. Thank you for having me.
All right, guys. Once again, thank you for joining us. We're always excited when you're here. Glad that you stopped by. If you're watching this on the replay, please go ahead and like it, share it with your family, share it with your friends. If you have women in your life, right, that you know of that are struggling with endometriosis, this is a good show for them. If you yourself have problems with endometriosis or other gynecologic issues, make sure that you try to reach out to Dr. White or to the OB in your area. If you have a male in your life, or if you are a male and you have a woman in your life and you recognize the symptoms, this is a perfect video for you to share with them and also for you to reach out, right? So this may give you a little bit of insight into what is going on and what they're doing, okay? And what they're feeling. So thank you, guys. This is Dr. Dwayne Wood, always here to educate, to empower, to encourage you to take charge of your health and your life. Avoid complications, live that healthy, fulfilling life that you want, and go to the next level. Thank you. We'll see you at the next video. Let's get some music and let's get on out of here.